The second part of the sensory lecture begins clients with auditory needs. By 2050, it's estimated that about half of all people over the age of 55 years will experience some degree of hearing loss. Early symptoms that clients have that have hearing loss include ringing of the ears, which is tinnitus, decreased hearing ability in large groups, increasing TV volume, and those types of things. Children with auditory disorders and dysfunction may have poor grades, safety issues, and also you will note the increasing volume on televisions and different things like that. This next slide looks at the anatomy of the ear, and just a reminder as far as transmission of sound, it starts in tympanic membrane. Sound transmits to the tympanic membrane, which then will transmit to the inner ear fluids and to the cochlea. This stimulates the hair cells in the organ of Corti to transform the mechanical energy of sound to neural activity. And then this is what is interpreted, these different frequencies, these get interpreted by cranial nerve number 8, which is the acoustic nerve, as actual sound. The next slide looks at conductive versus sensorineural hearing loss, and these are two different types of hearing disabilities that we're going to talk about on the next few slides. Conductive hearing loss looks at an actual loss of hearing due to interference with sound conduction. It's a problem with the outer or the middle ear, and it's caused by anything that blocks the external ear canal. So it could be something as simple as a buildup of cerumen, which is earwax, to an infection in the middle or outer ear, to a foreign body. And having worked in a pediatric outpatient clinic for several years, there are many, many things kids will put in as far as foreign bodies that can actually detract from their hearing and cause interference with sound conduction and all things like that. Sensorineural hearing loss, on the other hand, is a loss of hearing due to an inner ear problem. So this is a problem with the cochlea and the 8th cranial nerve pathway, and this can be caused by disease or trauma. It could be systemic types of diseases such as diabetes and arteriosclerosis, infectious diseases such as measles, mumps, and meningitis, local problems such as neuromas of the 8th cranial nerve, and also ototoxic drugs. There are many, many drugs on the market that if they get into elevated levels or toxic levels for a client, it can actually cause damage to the hairs in the cells of the organ corti, which can lead to hearing loss or deafness. So some of those drugs you probably learned about already in pharmacology and learned of this side effect, but just as a refresher, loop diuretics such as Lasix are one example. Chemotherapy agents such as cisplatin, anti-malarial agents such as quinine, salicylates such as aspirin and indocin, and chemicals such as alcohol and arsenic, and also many of the aminoglycoside antibiotics are known to cause potential hearing problems if they're at elevated levels. So probably one of the most common ones that we use quite frequently in the hospital setting would be gentamicin. And if you've ever noticed a patient that has a new order for gent, one of the orders will be to make sure that a peak and a trough level of gentamicin is drawn after the 3rd dose. And the reason for this is to make sure that that gent is in a therapeutic range for that patient and not at a toxic level, because if it does get to a toxic level, it can damage not only the hearing, but it can also damage the kidneys. So that would be one way to make sure that that patient isn't going to get into any side effects from that. If the patient would start to exhibit ringing in the ears, decreased hearing loss, those kinds of things from a drug that they're on, usually if they catch it very, very early, if that patient's taken off of that drug, then many times their hearing will be restored to normal. However, if the patient would be left on that drug for too long or it would be getting to a toxic level, then there is potential that that patient could have permanent hearing loss from it. Other types of antibiotics are your erythromycin family of families, like vancomycin, and also some of the gold metals and salts and things like that. Also, excessive noise exposure can cause damage to the hair cells in the organ of Corti. So OSHA gives regulations for when protective equipment is needed for hearing if the patient's in a work environment where that might be an issue. Presbycusis is simply old age hearing. It's a gradual hearing loss just from advanced aging. It's basically a decreased ability to hear high frequency sounds. The patient loses conversational speech, and hearing aids are very useful for this particular type of hearing problem. Probably a best guesstimate is about 60% of patients that are over 70 are going to have some form of presbycusis, just because it's such a common thing that we see. Some other risk factors for hearing loss: if there's a family history of hearing loss, that patient's chances are better to also exhibit some problems. Congenital malformations within some form of the ear canal or the ear pathway. Patients that have low birth weight, babies born less than 1,500 grams, that's a risk for hearing loss. We've talked about the use of ototoxic medications in the past. Patients that have had recurrent ear infections. Children that have frequent otitis media will come back in usually for routine checkups with a tympanogram to look for fluid still within the ear, because if they retain fluid in the middle ear, that can lead to some hearing problems. Bacterial meningitis is also known to cause hearing loss in some cases. And as we talked about earlier, chronic exposure to loud noises, and anytime there might be perforation of the tympanic membrane because of too much pressure or because of acute trauma. The impact of hearing loss on a patient: it hinders communication with others, it may limit their social activities, it may negatively affect their employment, and adversely affect overall their quality of life. Diagnosis of hearing loss can be done multiple different ways. One way is with audiometry, which actually can check the decibel of hearing loss for a particular client. Tympanometry we talked about earlier. That is an indirect measurement of sound transmission, and can see what's going on with that. Auditory brainstem response is where electrodes are placed on the head while the patient is seated, and then data is fed into a computer, and it looks at the electrical activity of the auditory pathway from the inner ear to the brain. This can help to diagnose different brainstem pathologies, such as stroke or acoustic growths and neuromas and different things like that. This is very similar that if you've ever had children of your own, and if there's any family history of hearing problems, your baby might have had a Bear test done, which is a brainstem auditory evoked response. It's kind of a similar type of an idea where they can check a baby's hearing. The other two tests that are listed there, the first one can actually test balance. The electron stigmography can look at balance and status of the whole vestibular system within the ear to look at a patient, why they might be having dizziness, vertigo, ringing in the ears, and all those types of things. So one thing that's observed during this test is nystagmus, which, remember, that's where the eyes go back and forth laterally. Assessment of the ear includes the otoscope exam, and with this is usually performed if the patient's suspected of having some sort of a problem. Assessment of balance is something that we as nurses can actually do to see if there's a problem with the inner ear structure and problems with a patient with vertigo and those kinds of things. So we can check a patient's gait, we can look for nystagmus, and we can do Romberg's test. A couple other tests that we can actually do as nurses. One is called the Rene test, and the other one is called Weber's test. And these will actually look at bone and air conduction. That's the Rene test looks at bone conduction versus air conduction to see which one the patient has better hearing with. And a normal finding for a particular patient would be that the patient should have air conduction more than bone conduction. Weber's test just looks at unilateral types of hearing loss. Treatment for patients with hearing impairments: one is to try to monitor noise pollution, wear ear protection. OSHA recommends that if a patient is going to be exposed to greater than 90 decibels for 8 hours or more per day in the work setting, then they need to have protective ear gear worn while they're in the work setting. And just to kind of give you some examples of what would be 90 decibels, a snowblower and a lawnmower would both be at around 90. And a rock concert would actually be at 120 decibels. So I always kind of wonder if Mick Jagger in his elderly years will have lots and lots of hearing problems, since I don't think that they wore ear protection in the younger days when he was probably young and doing concerts. The other thing that we need to teach patients is how to administer eardrops. do irrigations if those are ordered because of a buildup of cerumen and those types of things. Make sure patients are being monitored if they're on any of those ototoxic drugs. Teaching younger children or maybe confused elderly not to put things in their ears. And if the patient does suspect some problems, then having any hearing evaluations done. Communicating with patients that have hearing impairments, some good tips and interventions for them would be to talk directly to them face to face. If that patient is a lip reading in order to be able to hear or to be able to communicate with another person, talking slowly and in good lighting makes that a little bit easier for the person that's reading lips. If the patient has a unilateral type of a hearing loss, talk to the patient obviously on the side that's not impaired. Use gestures to help get across your point, and make sure patients are fitted with hearing aids if that's a problem that can fix the type of the hearing loss that they have. Many community resources are available for patients that have hearing disorders. We can hook them up with guide dogs from the International Hearing Dog Association. There's Deaf Resource Centers, American Academy of Audiology, National Institute on Deafness and Community Disorders, many places that we can hook our patients up to try and get them some help if they do have hearing disabilities. The next PowerPoint is going to look at clients that have sleep apnea issues. And sleep apnea is a very common disorder. It actually affects about 12 million Americans. And what it is soft tissue at the back of the throat collapses. This is due to decreased pharyngeal muscle tone during inspiration. And what happens is that actually blocks the patient's airway. It happens during sleep, and these patients will typically stop breathing many times a night. Could be for a minute, could be for longer. And besides just the fact that these patients have the periods of apnea, it can lead to systemic problems within the body. And multiple problems. So risk factors for developing sleep apnea include patients that are overweight, over the age of 40. It's more common in men than it is in women. Patients that have a large neck circumference are more at risk. I read an article at one point that said I think up to 30% of football players, professional football players, are at risk for sleep apnea because of the large neck girth that they have for football. Patients that also use alcohol and CNS depressants are at risk for sleep apnea, and patients that are post-op because of the fact of having had taken muscle relaxants during the surgery, and it can lead to hypoxia and those types of things. Basically, there are two types of sleep apnea, obstructive and central. With obstructive sleep apnea, the respiratory drive remains intact, but airflow ceases due to some sort of occlusion within the airway. So a good example of that could be that the patient has polyps or large tonsils or something like that. Versus central sleep apnea, which is a neurological disorder, which involves transient impairment of the neurological drive for the respiratory muscles. So how do you know if a patient has sleep apnea, or what are the symptoms? The patient typically will be the patient that has very loud snoring. They will have lots of gasping or choking during their sleep. And that's because what happens is as the apnea occurs, their blood levels of oxygen go down, and their body as a reflexive action gasps. They semi-come awake, take a breath, build the oxygen levels back up, and the whole cycle repeats again. The patient typically will have apnea for about 10 seconds or longer. And to qualify for sleep apnea, this needs to happen 5 or more times per hour. However, many patients that suffer from severe sleep apnea will have this happen hundreds of times per night. So in essence, what happens, those patients, because they're not getting a good night's sleep, they're waking up multiple times. They're very tired and fatigued during the day. They startle themselves awake as they're trying to sleep, so the sleep becomes very fragmented, and they tend to be very restless sleepers and that type of a thing. And as we had talked about before, if it's left untreated, it can lead to some pretty significant health problems, and those would include hypertension, cardiovascular disease, memory problems. The patient may have weight gain, impotency, headaches, impairment with employment due to falling asleep on the job, automobile accidents due to falling asleep because they're so overly tired because they're not getting into a good REM sleep. and into a good deep sleep when they are sleeping at night. So the patients are also at risk for heart attacks, which is myocardial infarctions, and strokes, which would be a cerebral vascular accident. Right heart failure is another issue and a potential problem for these patients. And if they had that, you might see edema, you might see right upper quadrant tenderness, nausea, and vomiting due to the abdominal distension. The patient may be anorexic because of the abdominal distension and accumulation of fluid and liver enlargement due to the right-sided heart failure. And those patients will be very fatigued. So how do they diagnose a patient with sleep apnea? Well, what they do is they bring them into a sleep lab. These are located within hospitals typically, and what they'll do is a sleep study, which is also known as a polysomnograph, and it's an overnight sleep study where the patient is actually hooked up to all sorts of monitoring devices. They will do an EEG while the patient's sleeping. They will look at deep sleep, rapid eye movement. They'll look at respiration and airflow, so they'll have a pulse ox on, a continuous monitor looking at their oxygen sats as they sleep, and they'll also be hooked up to a cardiac monitor so that they can be looking at any heart rate changes or arrhythmias that patient may have as they're exhibiting sleep apnea symptoms. It's treated in many different ways. Depending on the severity of the sleep apnea that the patient has, there are methods that they can do as far as trying, if the obesity is the issue of why the patient has developed it, weight reduction issues. If the patient is also using CNS depressants and alcohol, and that's leading to sleep apnea issues, then obviously getting them off of those particular things. Also trying to have the patient sleep on their side versus their back. When they lay on their back, that just makes that pharyngeal wall muscle that's already weak worse. So having the patients turn on their side helps a little bit to keep that airway open. And they can be fitted for oral appliances to keep the jaw and the tongue forward, which keeps the airway open. Medical management may include medications that increase the respiratory drive and improve upper airway tone. And one example of one type of medication that falls into that category would be protriptyline. Patients will probably also be fitted for a CPAP or a BiPAP machine. This is CPAP is actually known as continuous positive airway pressure, and this is a tight-fitting mask that prevents collapse and obstruction of the airway. You can see a picture of that off to the right there, and you can also see a picture of it on the patient down in the right-hand corner. With a BiPAP machine, it does something very similar to a CPAP, but it delivers high pressure during inhalation and a lower pressure during expiration. So there's a little bit less resistance to exhalation. So it's going to depend on which one the physician feels will work better for that particular patient's scenario. The machine is not typically hooked up to oxygen unless the patient would warrant that, but they do make, some noise, the machines do, but if you talk to enough patients and their significant other, they will say, the significant other says it's much better to listen to the humming of the machine running all night long than to the snoring and the thrashing and all that of the patient that suffers from sleep apnea. The problem is, as you can see, compliance issues. A lot of patients don't like to wear those to sleep at night. Or during the day, depending on when their sleep cycle is and their work schedule and that type of a thing. So some patients get fitted for them, they get them, but then they don't wear them on a consistent basis, and so the problem continues. If the patient, for some reason, the BiPAP or CPAP machine was not fixing the problem, the patient could be a candidate for a surgery called a UPP surgery. And this stands for uvulopalatopharyngoplasty surgery. And this is actually where there's removal of the obstructive tissue from the soft palate, the uvula, and the posterior lateral pharyngeal wall. So as you can see to the picture of the right, there's a lot of the oral pharynx that's removed. So it's a very significant surgery, and the patient would really have to discuss this with the physician to see if that's something that's needed. It's about a 50% success rate in treating sleep apnea, especially this obstructive type of sleep apnea. And if this would not work and the patient was still having lots of issues, the last resort method might be that the patient has a tracheostomy done. These are good calls for nursing for your patients that have sleep apnea, obviously sleep pattern disturbance, knowledge deficit related to many, many different things, perhaps the importance of using the BiPAP or CPAP machine on a regular basis. Patients may have, like we talked about earlier, a lot of fatigue and employment issues, so those may be things. So you can read through those calls of nursing on your own. Nursing interventions include teaching and counseling, getting patients into weight loss programs if obesity is the issue, airway management types of nursing interventions, and getting them into a sleep apnea support group would be very helpful.